So my next presentation is on atrial fibrillation and the pulmonary vein isolation for treatment of AFib. So atrial fibrillation is a growing health problem. It's the most prevalent arrhythmia and is associated with an increased risk of stroke. It increases the risk by 5 times, increased morbidity and mortality. Antiarrhythmic drugs are currently the first-line therapy for patients without permanent AFib, and this fails to prevent recurrences in over 50% at 1 year. So the role of pulmonary veins in AFib, the pulmonary veins in the left atrium are responsible for the initiation of AFib in 80 to 95% of patients. So the vast majority of patients with AFib, the culprit is those pulmonary veins. So if they decide to ablate AFib, they target the pulmonary veins and do a pulmonary vein isolation PVI to eliminate foci. I'll show you a diagram or a picture. Clinical outcome for PVI, it's at present the reported efficacy of PVI to terminate paroxysmal AFib is 65 to 70% after 1 ablation. So if you compare this with AVNRT or atrial flutter, the efficacy is 95%. This is a little bit lower, but it's getting better and it's still a great option for patients. Patient selection, you look at their CHAD score. If their CHAD score is less than 1, pulmonary vein isolation. Anticoagulation remains the cornerstone of AF treatment and should be continued in patients with CHAD score greater than 1. So do you know what CHAD score stands for?
Hypertension, age greater than 75, diabetes, previous stroke?
Stroke.
That's 2 score.
Yep, stroke. Great. Okay, and it's saying that AFib ablation is getting better and better. Okay, so there's 3 main targets for ablation of atrial fib. Isolation of the triggers in reentrant circuits, disruption of the rotors, and ablation of ganglionated automatic plexi. I'm really just going to talk about a PVI because that's really what you're going to see in the lab. It's the most common, but there are other targets. And there are other companies that help with finding rotors and that such thing. Okay, so the pulmonary veins are in the left atrium. The 4 pulmonary vein junctions are found in the left atrium. You want to electrically isolate them. So what you do is you put a catheter up the IVC, cross the atrial septum, and you can map and see if they have electrical signals, if they're propagating inwards or outwards, and you can pace around. There are circular catheters designed for this purpose. So there's 3 different patterns of AF. I'm sure you've heard of these: paroxysmal, AF lasting less than 7 days, persistent, AF lasting beyond 7 days, and permanent, which cardioversion failed. So the role of pulmonary veins in AF, it's now widely accepted. That's where AF originates. And the signals, instead of the signal originating in the SA node, there's rapid and chaotic signals originated in the pulmonary veins. So when you're going to ablate the pulmonary veins, the first thing you do is get venous access. And then you put the catheters in the right atrium and you have to cross the atrial septum. If the patient has a PFO, patent foramen ovale, just go right through the hole. But typically you have to cross it. And you do this using a needle or RF. And you use ICE, intracardiac echo, to make sure you have good tenting, because the septum is the only structure that will have a nice tenting look to it when you poke at it. So I'll show you what tenting looks like. But this is a nice diagram it's a nice picture because once you cross it, your catheters almost always go straight to the left superior pulmonary vein, and that's kind of where you start because that's just where everything goes. But this is a circular catheter designed for atrial fibrillation for the pulmonary veins. So what they'll do is they'll place it in the pulmonary vein antrum, kind of in the entrance, and then put it in the pulmonary vein, pace from either side, and make sure that it's isolated. So these are ICE images. I think the best picture is C, and that's what shows the needle tenting. So you can see here's the needle here going from the right atrium to the left atrium, and see how it looks like a tent. That's a great sign. So then once you cross, you can see it crosses here. Usually after you cross, you shoot bubbles. They're not air bubbles, it's just you shoot the contrast contrast really fast. It looks like bubbles, and you can tell that you're in the left atrium because the bubbles will be in the left atrium, not in the right. But they're kind of out of order. So pretty much in a PVI, you have to be really careful about anticoagulation because you're in the left side. Usually before you do a PVI, you do a TEE, a transesophageal echo, to make sure there is no strokes. Strokes often hide in the left atrial appendage. And then throughout the procedure, you check the patient's activated clotting time. Their ACT is around 300 to 350. So you'll hear the doctor, every so often ask what the ACT is. So risks and complications. There's a 4 to 6% rate of major complications with a PVI. I guess mostly what I want to say about this is the complications are getting lower and lower, but there's a posterior perforation risk, and on the posterior side of the heart in the back, it's a lot thinner. So when we're ablating back there, we'll dial down the wattage on our ablation catheter, maybe 20 watts instead of 35 watts, so you don't perforate. Then strokes and complete pulmonary vein stenosis may be a complication, but that's getting less and less. We're in the EP lab, they've been ablating less and less, more distally in the pulmonary veins. They kind of stay around the os now, so pulmonary vein stenosis risk has been decreasing over the years. Okay, so isolation of pulmonary veins. In this image, they've already crossed the septum, and the mapping circular catheter goes from vein to vein. And then this is just a diagram, but to isolate the pulmonary veins, they'll either draw big WACA circles, wide area circumferential ablations, around the right side of pulmonary veins and the left side of pulmonary veins, or you'll do vein by vein. And it just depends on the anatomy and what you're going to do. I used to think, oh, let's see which one I do more frequently. It just depends on the anatomy. So this is a fluoroscopic view, an AP view of the multipolar circular mapping catheter called a lasso. And it's designed for pulmonary veins. Here's the ablation catheter. It has a little bit thicker tip there. And then the decapolar catheter is placed in the coronary sinus. So this is an image from Cardo. There's a lesion set after the PVI. So in this image, they did circles around each of the veins. So after you do your ablations, then they'll move the circular catheter in the vein, pace, make sure it doesn't capture the rest of the atrium, and then also put the ablation catheter in, pace the atrium, make sure it doesn't go into the pulmonary vein. A bidirectional block. And then here's a lesion set after a PVI using St. Jude EnSite. And as you can see, they did two on the right side of veins. They did circles around each of them. On the left side, it kind of looked like a common os, so they just did one big circle. So here's just intracardiac showing entrance and exit block. So on the left image, it's before the pulmonary veins. The circular catheter is put in the pulmonary vein. You can see there are potentials in there, and then afterwards, clearly there are not. And then you do circumferential pacing, so you pace on each of the electrodes in the circular catheter.
Do you guys get what that is?
Yeah, so this is what we were looking at during the last procedure. So each of those is like between 2 points in that circular lasso, right?
Correct.
So on the left one, we see spikes, meaning there's conduction across the lasso
into the pulmonary vein, yeah.
Right. And then after that, after the ablation, there's no signal coming through.
Right. So we know that it's electrically isolated, that no signal from the atrium is getting into the pulmonary vein.
Okay, right.
Yeah.
So is there, what's initiating the pacing? So the lasso is sitting at the pulmonary vein.
Yes.
And then the heart's obviously already speeding, so it's just the natural signal that we're keeping track of, or are we like, sometimes we would say like pace the heart?
Right, right.
So is there another cathode there, or is there another
signal?
thing in there? What's actually causing, how are we causing the pacing?
Oh, sure. So we have a mapping system and also a pacing system in the lab, so you can pace from any electrode inside the heart. So there's a pin block, and then it's hooked up to, I believe at Tarzana, I forget which company they have, but it's they can do a full EP study where they can pace from any electrode.
So
it's equipment.
But it's through the same electrode. There's just two things right now in the heart. There's the lasso, and then there's the ablation.
Correct, yeah.
catheter, right? So is those one of those two things that cause the pacing?
Yep.
We want to test it?
Yes, you can pace from either one.
Okay, got it.
Yeah.
You can-
Yeah, good question. The smallest words ever, but in summary, atrial fib is a growing health problem. Pulmonary veins cause AFib in 80 to 95% of patients. To ablate this, you do a PVI, pulmonary vein isolation, and the outcome is, after one ablation, it's 65 to 70% effective. Patient selection, you look at their CHAD score, and if it's greater than 1, you anticoagulate even after the ablation, even if they're in sinus rhythm. And then, in conclusion, atrial fib ablation is getting better and better as the years go by.